So the midwives need to put out a code to get us there, preferably prior to delivery if it's imminent. But delayed cord clamping is one of the most important aspects of management of extremely preterm babies. And we want to ensure that 30 to 60 seconds of this happens. Now, culturally, we're not allowed to be visible to the mother. And that is a real challenge. So our midwives have had a lot of training in managing delayed cord clamping. Is the baby breathing? Is he showing signs that he's vigorous? He's not flopping tail. Well, we want to ensure that he gets 60 seconds. But we also want to ensure that he goes into a plastic bag. So our plastic bags are kept on in the rooms. So that as soon as the baby delivers, no cleaning and wiping, the midwife will put him into a plastic bag while the cord is being filled. So that means that when I arrive there, the baby's already in a plastic bag. In theatre, it's easier. You can be put in a plastic bag straight away. But more importantly, as soon as we arrive, the airway one person basically works towards beep if the baby's breathing over 26 weeks, or works towards beep and IPPD if the baby's not breathing with a view to intubating. What we want to achieve is 30 to 60 seconds of delayed cord clamping, simultaneous thermal care to achieve an outcome of 36.5 to 37.5 by 10 minutes of age. And by 5 minutes of age, based on Decker's work, we want to achieve a heart rate of about 100 with saturations of 85%. Now, I'm not saying this high quality evidence based on Decker's standards that this is really something that we should aspire to, but it is an outcome-based measure that we have chosen as part of quality improvement that we aspire to in our unit, because there is low quality evidence that decreases the risk of IEH, and we have an IEH rate of 10%. So really for us it's quite important that we work towards it. Clinical perfusion is more assessed. I know that in certain countries, and I will show you a paper, they are now using mirrors in the delivery room, and they're measuring cerebral saturation indices to kind of establish that we have good cerebral perfusion by about 15 minutes of age in babies who are being resuscitated for extremely preterm. They have developed centiles to this, which were just published day before yesterday. At the end of the day, the DT-ABC approach needs to be completed within a finite time. So I'm just giving you a flavor. We had people spending 40 minutes resuscitating babies, 23 weeks in our delivery suites. The golden hour is gone. We have no access. What is the baby's glucose? We were struggling because we couldn't achieve those targets because the amount of time being spent handing over and documenting whilst we're bringing the baby to the neonatal unit is actually resulting in poor outcomes. So we worked on that. I've talked a little bit about delayed cord clamping and the processes. We followed a time-based physiology. We do not provide ventilation at this particular point whilst we're doing delayed cord clamping. Anybody here providing ventilation with their ACC?